other studies and presentations that you'd like to mention?
Well, I think a really important bone-related study here at the San Antonio Breast Cancer Symposium is a study called the Azure trial. And it's a trial looking at whether or not Zometa, or this class of drugs in general, the bisphosphonates, actually can prevent bone metastases. That's been a really hot topic, especially for the past few years, after we saw a presentation a few years ago of an Austrian study of premenopausal breast cancer patients who were given Zometa just every 6 months, really to help their bones more than anything. And almost surprisingly, we saw that it reduced recurrences in these premenopausal women who weren't getting chemo by about 34%. But we took a look at that, said that's not a common group of patients, estrogen receptor positive, premenopausal, not getting chemo, so it didn't really apply to everybody. We've all been waiting for this Azure trial, which took pre- and postmenopausal women, women who got chemo or not, women who got endocrine therapy or not, and randomized about a little more than 3,000 women to get Zometa, given kind of in a mix of the bone met treatment dose and the osteoporosis dose. So it was monthly for 6 months, as if you had a bone met that you couldn't see that was hidden in the bone that you were trying to get rid of. And then it went to every 3 months, and then it went to every 6 months. So a more mix of a bone metastases treatment dose and an osteoporosis dose versus nothing, no Zometa. They got chemo, radiation, surgery per standard. And disappointingly, the overall trial result is that there was no difference in the group who got the Zometa versus the group who didn't have the Zometa added in terms of recurrences or in terms of deaths. So that was pretty disappointing. And yet, a pre-planned sub-study analysis of the 1/3 of patients in the study who were definitively postmenopausal, meaning a good 5 years from menopause, were sure they didn't really have any circulating estrogen. That had been pre-planned, and that showed an overwhelming positive result. Less recurrences, less deaths statistically held up in a meaningful way, not just a few less. So how do we explain that? We've been racking our brain over the past few days since we've seen the results, and there must be something due to a no estrogen or low estrogen state. In the Austrian study, I told you they were premenopausal, but they all had injections to shut down their ovaries as part of their treatment. In this study, the Azure study, the group that appears to be benefiting are those who were definitively postmenopausal at the time they entered the study. So how do we explain that? What are we going to do with further studies? We have a few more that are going to report within a few years, and we really need to plan ahead to be able to look at this postmenopausal group, I think. Otherwise, it might just be a wash in these studies, and we might have a bunch of negative studies when a subset of patients are benefiting. Fascinating data. We're still trying to explain it.
So this is going to take a while for probably changes to actually happen in the overall clinical. 82% of patients are treated in the private practice. So
Right.
How do you see all this playing out for patients that aren't seen at large academic centers, but out there in the community?
Right. So, well, first of all, I think so Zometa can be given for osteoporosis or for treatment of bone mets, and so we still need to, even in these early stage patients, be looking out for the bone loss and taking care of that, and in some instances an every 6-month dosing of Zometa for maintaining the bones and preventing fractures is reasonable. I don't think that this study would tell any of us that we should give the more intensive dosing in early stage breast cancer to prevent recurrences, but that every 6-month dosing in the older Austrian study is reasonable both to prevent bone loss and maybe we'll sort it out someday, it's reducing recurrences. And I think, that's the message for everybody, is that there are probably patients who are at more risk for bone metastases and bone loss.